You're listening to the Physio Matters podcast this month in association with the Royal National Orthopaedic Hospitals charity, and this is a special bonus edition for COVID-19. Welcome back to the Physio Matters podcast. I'm Jack Chew, here with one of several emergency editions of the show. To set the scene in case you need me to, this is rather serious. The date is the 21st of March 2020 and we're in the midst of the COVID-19 coronavirus pandemic. I'm a healthcare professional, I own a healthcare business, host a healthcare podcast and the director of a healthcare think tank. And in each of these roles, I see unique opportunities to help, and it's because my audience here and on social media are incredible. It feels like my duty and therefore goal to get as many of you efficiently contributing to the current and future care efforts as possible. As this episode lays out, there's some vital ways in which MSK therapists can help with the care efforts, but also some terrible ways in which well-meaning clinicians can hinder or negatively disrupt care delivery. I love that everyone in my network seems to be asking themselves, what can I do? So I've done the same whilst wearing all four of my metaphorical hats I've just mentioned. So, number one, as a healthcare professional, I'll be leading by example and ceasing all face-to-face care for the foreseeable future. We must practice social distancing to flatten the pandemic curve and reduce the strain on our health service. This is from my observations of expert analysis as well as the hard science itself. Number two, as MD of Choose Health, a MSK clinic in Manchester, England, I realise that we have the expertise and infrastructure through our partners at Physio Fast Online to support virtual consulting. We also have national and international reputation as well as a local one, so may be able to help promote quality clinicians to deliver virtual clinics and keep patients away from the cowboys who will simply switch their snake oil massage to snake oil virtual rehab. Keep an eye on mine and clinical lead Mark Reed's Twitter feeds for opportunities to join Choose Health as a digital associate and stop everyone having to do their own little thing. As host of the Physio Matters podcast, I realise my responsibility to ask the questions on my audience's lips and find the experts best placed to answer them. This starts with this episode, and we have prioritised at least 3 emergency podcasts that will be released ASAP. Virtual consulting and workforce planning and leadership are already in the pipeline. I'm also working with other organisations to digitise their work as quickly as possible. And if you've had to cancel a CPD or trade event due to COVID-19, please get in touch and see if we can help. As Director of MSK Reform, I realise my responsibility to help identify and mobilise the MSK rehab workforce so we can be ready for when we're needed. So the final but most important call to action from me today is for you to visit mskreform.org.uk/rehab recruits to declare your interest in helping the UK care efforts. Today's podcast merges 2 conversations I've had this week with this consultant respiratory physiotherapist Rachael Moses about COVID-19 and what MSK therapists should and shouldn't be doing. If you're one of almost 50,000 people who watch the 30-minute chat on Facebook or YouTube, then skip ahead 30 minutes to our second chat, which really adds some meat to the bones on our suggestions, including why you really should be putting your stethoscope back in the loft and start sharpening your functional rehab skills. Huge thanks to the Royal National Orthopaedic Hospital charity, who sponsored this podcast for urgent production and release. The RNOH's patients are in great hands with a leadership and staff base who are craving practical advice to best help in this crisis. When all this settles down, remember their thoughtfulness and generosity at this difficult time and send your complex cases for expert opinions. They really are the best in the business. So that's enough from me. I'll see you at the other side, and thank you for listening. So I'm delighted to be here this evening, a Saturday evening after hours, at a very unusual time of day as well as time of our lives, I think, really, in a unique situation managing the coronavirus COVID-19. And as MSK physio myself, and also within the role that I have as a digital educator, it feels a really strange thing to feel quite powerless, but also feeling also responsible to try and accentuate good messages and sometimes even counter bad ones. Now, one of the things that I've been doing recently is sort of speaking my opinion as to what I've understood as being mechanisms and some of the epidemiology and just trying to feed that forward. This is not what this is. So you might have seen that on Twitter. That's not what we're doing here. Instead of talking strategy or even musing over policy, this is something that instead I wanted to get a good friend of mine, Rachael Moses, who is a consultant
consultant respiratory physiotherapist who has been doing a lot of the thinking on this in the practical, pragmatic side of things and understanding what's going on the front line and trying to make sure that we can mobilise a sensible workforce efficiently and safely as can be, of course. And so that's going to be what we visit in this conversation and talk through some of those things. So the places where we don't go, we are preparing some other information and education alongside other providers just to make sure that we maximise the impact on the airwaves at the moment. But generally speaking, that's what we are and aren't going to be talking about. But I want to thank Rachel before we even get going for coming on the show at this time of night and time of a very busy period for her, as you can imagine. And so, Rachel, in case I've missed anything else in your intro, could you let the listeners know a little bit about your roles and what we've been talking about?
Thanks, Jack. So yes, I am a consultant respiratory physiotherapist, and my speciality is in long-term ventilation. And so that's anything from a patient being stuck in intensive care on a ventilator that we can't wean, and either liberating them from the ventilator or if we can't, setting them up on a ventilator to go home with. And that includes like airway clearance, so some of the cough assist machines you might have heard of, tracheostomy care. So everything around that very, very acute stage of respiratory medicine all the way through to home and community care, and then, of course, end-of-life care planning. And I mainly look after adults. I do look after some children, more transitional age, kind of teenagers. I definitely don't do babies. They're a unique speciality, but that's kind of like my cohort. Right. And obviously this is why I take a bit of an interest in what's going on at the moment. And I'm speaking on behalf of myself, really. My trust are incredibly supportive of some of the work that I'm doing at the moment, which is some standalone document work. And my other role is on CSP Council, which I'm obviously not speaking on behalf of the CSP either. So,
of course, no problem. Yeah, no, that's great. Thank you very much for that. So one of the questions I really wanted to dive into was, what does care of COVID-19 patients look like?
So that's a really, really great question. So if we think about what the coronavirus is, it's actually a group of viruses that exist around the world, but we have particular strains, and COVID-19 is a unique and new strain. So we don't really know how to manage it. We have no vaccine, we have no immunity, and we're really kind of trying to understand how this virus presents. Now, it's changing all the time, I will say that, and the most recent kind of evidence that we have, the most up-to-date evidence, is it's very much presenting like the Sars virus, which people may remember from the early, 2002, 2003, 2004, and that was kind of the last pandemic that we had. So these patients will tend to present with obviously a temperature of fever, and that's above 37.8, so that would be the numbers that the government are providing us with, and a cough, and that's a cough that's continuous and new in presentation, so not a chronic cough. And they're the two things that people are looking out for now. We tend to have 3 stages, and that's what certainly our colleagues in other countries are saying. So you have the initial flu-like stage where you might have the respiratory virus stage where you have a cough or cold, and you generally feel unwell. That moves on to a pneumonia stage for some people. So pneumonia is what we classify as a significant or severe chest infection. And then you have the late stage, and these are the minority of people, but these are the people that are needing to come into hospital, and they develop an acute respiratory distress syndrome where their oxygen levels are very low. And these are the types of people that need help with their ventilation. So they will be intubated, or we support them with ventilation non-invasively, but that's kind of a grey area. We don't tend to do that. We tend to just intubate them and pop them on a ventilator in intensive care. That would be the primary management for these patients when they present critically unwell.
So one of the things that as MSK physios, sometimes it's a while back that we touched on some of those things you're describing, and so sometimes we sort of have this catch-all respiratory physio sort of toolkit that we recall, be that manual techniques, ACVT, various different devices that we might or might not have used. Obviously, on an individual patient level, it may well be that any one of those things might be relevant or not, but in this instance, it is particularly trying to intubate the right patients that are critically unwell, and that really the interval stuff I've described there isn't as important as considering the policies that we're talking about.
Absolutely, Jack. I think that's the big take-home message. These patients have ventilatory failure. It's a virus, so it doesn't respond to a lot of therapy. And if from what our colleagues are telling us in other countries who are dealing with this pandemic on mass scale, that is the primary treatment is to ventilate. Now, obviously, there becomes a capacity issue, and that's what some of our colleagues are seeing, particularly in Italy, that there's a limited amount of intensive care beds, and not everyone normally will get offered intensive care treatment. So there would be, it's not a given for everyone. For example, if someone's particularly frail, we don't tend to go off age so much, we go off frailty. And a lot of comorbidities, existing preconditions, and some people might already have a ceiling of treatment in place. For example, they may not be for intubation, ventilation and intensive care. So if these people are presenting with COVID-19, then that does become a challenge for healthcare as well, because intubation can't be the default. And that's maybe where respiratory physio and other physiotherapists potentially in the future might come in.
Okay, no, it makes sense. Now, one of the things they've been saying about it being a particularly dry cough and therefore not productive, that maybe is when I think about what the care delivery is, when people are thinking about whether their skill set is or isn't up to scratch to help, one of the things that I've been hearing from people is, I haven't done vibs and percussions and suction for years. And I'm like, well, I think at the very least you're in a situation where your reasoning is going to be more important than those particular skills. Now, am I wrong to be reassuring them in that direction?
Absolutely. I mean, from what our colleagues tell us again, it's a non-productive condition, and we're not seeing a lot of intensive respiratory physiotherapy needed in the intensive care units. Of course, there will always be people that present with COVID-19 with underlying conditions, but that we're just not seeing that at the moment. So yeah, that would be an accurate reflection, Jack.
Good. Well, I'm glad I've not given any further misinformation then. But I can understand those instincts, because sometimes we sort of lump those things in. It's just chest stuff to us sometimes, and so we need to try and cut through that and be a bit more specific. So that's helpful. What are the risks to physios?
So if we're talking about acute physiotherapy, so physiotherapies that we're working on intensive care, on the wards, in the emergency departments, that are frontline, respiratory or medically trained respiratory physios. There's obviously going to be a risk of exposure to the physiotherapist. There's going to be a risk of exposure and transmission. So us kind of passing it on to the patients if we may be unaware that we have the virus. So really what we need to be mindful of is minimising the risk and really adhering to personal protection equipment. Very, very clear guidelines from the government, from Public Health England, about what we should be doing, and they're absolutely being adopted at local level within trusts. So of course the risk is that we're going to contract. Of course the risk is then we might transmit, might unknowingly transmit, and that is the worry with healthcare workers. And certainly in Italy, that's what they found. A number of healthcare workers unfortunately have contracted COVID-19. So we need, in the UK, we're really mindful of that.
Sure. Yeah, because so the risks to physios are the risks to the population, but just heightened because of exposure.
Exactly. Now, if you think about your MSK physio in an MSK department or in a private practice maybe, then those risks do exist. So certainly the advice I would be given is screening your patients before they come in. I think we're absolutely in across community and across outpatient settings. You would screen all of the patients that would kind of come into your clinic. Now that could be phoning them up beforehand and saying, have you got any of these symptoms? That could be as they're coming into your clinic. Have you had a temperature? Obviously you've got all the travel screening questions that hopefully everyone's aware of now. Have you got a temperature? Have you got a cough? Do you feel unwell? Have you had contact with a person who has now been diagnosed or is in self-isolation with COVID-19? Because if they have any of those things, you don't want that person coming into your clinic.
Yeah.
And then when you do treat someone in your clinic, you have to be extra vigilant about hand hygiene. Alcohol gel if you can get it, if you have it in your practice, wiping surfaces down. I can't stress how important that is to minimise the risk and to prevent transmission.
Absolutely, no, that's really valuable, and hopefully something that people are starting to really crank the gears on. But sometimes there's a complacency in outpatient and sports environments compared to acute. But definitely we all need to be starting to do that generally. And I think over the weekend we're witnessing people feeling like that in public spaces anyway. We're seeing various different places taking those precautions. So I'm glad it's moving in that direction. So thank you for that. With regards to mitigating them, is there anything else that we need to add on that, particularly for physio physios and the ways in which that they can further protect themselves?
So if we're talking about in an acute environment, again, we are following Public Health England advice, again, which is very clear in terms of they just hot off the press last night / this morning have new infection control guidelines, which is a collaborative approach to what we should be doing. In terms of respiratory physiotherapy or acute physiotherapy, this is exactly the reason I put my little document together in terms of it could collaborate all the information, all the guidelines, because it's in lots of different places at the minute on the internet and on the government websites. So it brings it all together in terms of preparing ourselves, so keeping ourselves clean and virus free, using the right personal protective equipment, and that includes things that we do as physios that maybe aren't listed on the government pages. So any aerosol generating procedures that we do, basically get any technique we do to get the patients a little bit out of breath, to get them coughing, to get them up, to get them mobilising, because this isn't just in the very acute phase, it's when we're starting to rehabilitate the patients and, maybe on a ward or a cohort environment. So all of these little things to try and keep ourselves safe, our patients safe, and then of course we go home. So there's a big thing around uniforms and about wearing, keeping your uniforms at home, at hospitals, so wearing scrubs if you're in a cohort infected area, or if you're going to see positive patients. And then if you do wear a uniform, bag your uniform up at the end of the day, take it home, put it through a hot wash. How many times do you see, not just physios, other healthcare professionals leaving the hospital in their uniforms? So we're really trying to stamp down on this as well. So looking after ourselves, the public, or family. Wash your hands all the time, especially when you leave work and get in from work. So first thing everyone should be doing.
Yeah, absolutely. No, that makes sense. And I think one of the things that I certainly, until I was preparing for this conversation, I hadn't really given thought to the fact that down the line in weeks and months to come, we're going to be needing to rehabilitate these patients, and that's going to present itself with new challenges, but it's super important because that will hopefully clear the way with regards to beds and facilities, and so it's really important work that's going to be done. But that will aerosolise. We will be getting people working and exercising in various different parts of the hospitals, perhaps, and so we need to have vigilance across the board as well as in the community, which I'm sure we'll be coming to. So yeah, it's a really good point that I definitely didn't think of. You think of the really acutely unwell, but fundamentally they need downstream to be phased back out, especially to make way for the next batch, unfortunately, because of the pandemic nature of this, of course. So one of the things that I wanted to ask, that a term that I've been hearing that I didn't really understand until a bit of Googling and obviously asking around, is what is fit testing?
So anyone who requires the use of respiratory protective equipment, and that is normally in the face of a respirator mask, requires us to know that mask is working and it's effective. So the fit testing that we do in the NHS is basically like a hood that comes over your head, and it's sealed at the bottom around your neck, and it has a small hole around about where your mouth is. And it involves, it's got two sprays, it's got a bitter and a sweet spray. It involves doing a sensitivity test first to say that you can taste the bitter spray, and you then, not on the same day, you normally do your test first and then do your actual fit test later. Then it involves fitting a respirator mask, we use the FFP3s, which are the standard recommended masks. You pop it on, you fit it well, so there's diagrams about how you fit your mask respirator well, and then you put your head inside this hood, and then you basically get spray inside the hood, and you have to do different types of exercises in the hood, like moving your head from side to side, down to down, forward, and walking, just to make sure that mask has a really good seal. And then if you pass the fit test, you know that mask is going to be absolutely spot on for you if you have to go and treat an infected patient. So interestingly, just last night, the guidelines changed, so all staff had to wear full masks, like respirator masks, when they're seeing COVID-19 positive patients. But now those masks are only to be used if you're doing an aerosol generating procedure or you're working in a critical care environment. So the surgical masks, the other masks that you can get, they're just like the theatre style masks. They are now absolutely safe to use with these patients, as long as you're not doing aerosol generating procedures. And an aerosol generating procedure is just exactly what it sounds like, something that you're going to do that makes the patients cough and produce respiratory droplets, because that's how this virus is transmitted.
It might be more contentious than I'm meaning to be, but do you think that is that because of supply and demand, or is that because there is good evidence to suggest of safety?
So this again has come from some of the epidemiology of what we know about the virus now, and in my very limited understanding of all of this is, again, relating it to the SARS pandemic. They're seeing lots of similarities, and there was a paper, I think it was a Hong Kong team, that looked at the effectiveness of, they'd done a meta-analysis after the SARS virus, and they looked at the effectiveness of surgical masks and the FFP3s, and there was an 80% similarity between the two masks in terms of being completely effective in terms of the non-transmission of the virus through either mask.
Right.
So, I mean, we have heard of some trusts that are having supply problems with FFP3s, but as far as I'm aware, those supply problems are fine now. We don't have problems in our hospitals, so I don't think it's because of lack of masks. I think it's a genuine, scientifically proven, safe concept.
Good. Well, that's reassuring. As I say, I wasn't meaning to sound too cynical, but sometimes you do wonder if they're just laxing in those for the reasons of supply. So that's promising. Pleased to hear that. One of the things that we're talking broadly on, but obviously our audience is typically MSK therapists of various different flavours and people interested in MSK. And so what could MSK therapists do now, do you feel?
That's a really great question. So this is my personal opinion. So probably some of my colleagues might not agree with me, but in terms of musculoskeletal physiotherapists being on on-call rollers and doing specialist respiratory techniques, I absolutely do not agree with. It's more hassle than it's worth. I can't do your job, and why should I expect you to come do my job? And in my experience, when MSK physios have done things like that, it's led to huge problems, not just with anxieties, but about competencies and actually safety. So that's the bottom line for me. But do MSK physios have a role in this pandemic? Do they have a role in frontline physiotherapy? Absolutely. Now, in terms of what MSK physios can do will absolutely depend on the arena they're working in, like you said. So if you're a private practice MSK practitioner that maybe has never even done hospital work before, because we obviously we're seeing that more and more now, don't we? Back in probably your day and my day, everybody came through the NHS, everyone done their rotations, so they had some experience. It's very unlikely that you're going to be drafted in and asked to come and help in the acute environment. Your skills might lie more in the community sector. For those MSK colleagues, and I know lots of my colleagues who have excellent skills in rehab, and in even just that frailty stage when we need to get people up and get people moving again, and that still being able to care for people, have that conversation with them, in terms of maybe functional activities. I absolutely see a role in MSK physios. Now, in terms of what can you do if I take it back a step, what can you do as a profession? So if you're an MSK physio or an MSK team lead in the department, my big ask is you're just mindful to what's going on. You're mindful to what your hospital's going through. You're mindful of what your preparedness plans are. You're mindful of what the government advice is. You're mindful of the information that's provided for employers and for people who are working in acute healthcare services. You absolutely know how to minimise the risks. So everything was said before about hand hygiene, about being absolutely anal about your cleaning of your plinths, of your areas, actually allocating someone to that, give your staff time to do that. It is not going to be long at all if your department hasn't already shut down outpatient activity. Most trusts now are at the point where we are going to shut all outpatient activity. So, and the main reason for that is to reduce the footfall through the hospital. So reduce the amount of people coming into hospital, not just about virus transmission, but just about sheer numbers. Some trusts have already done that. It might be essential kind of outpatient activity only when we think about lung cancer patients, etc.
Sure.
So if that's the case, you really need to think about what your unique contribution is to your department. So again, it will depend if you're a major trauma teaching hospital or if you're a district general or if you're a community provider. But what is your unique contribution to your preparedness plans, to the pandemic plans that your trust have? And the other thing is, can you support your inpatient teams? How can you do that? Do you have rotational band 6s? Do you have rotational band 5s? Do you have band 7 pain specialists? Your super specialist MSK physios might actually have the least that can contribute in terms of clinical, but they might have the most in terms of strategy, operational, supporting that other 8A respiratory physio, supporting the departmental manager. You know, this is a stressful time for people, and they have to make decisions that affect huge numbers of staff that are worried about their families. They might have small children, some of our staff might be pregnant, some might be immunocompromised, some might have elderly parents, and of course some staff might contract the virus as well. So in terms of if your department makes a decision about MSK staff being mobilised to help frontline, it has to be safe. So MSK physios are well within their rights to say, okay, here we are, we're willing to help. What's our contribution going to be? And if it's asking them to do something that's slightly outside of the skill set or something they haven't done for a long time, ask what the training is. So we'll be putting training on in our hospital. We're already doing it, specific training for respiratory physios and for medical physios, but actually understanding what we're going to be asking non-acute respiratory medical physios to do.
Yeah, well, I mean, we're 22, 23 minutes in, and I don't think I've been a prick with a question yet, but I'm afraid I might change that, I'm afraid. Because one of the things I want to ask you now, from just what you've said there, that I think is probably awkward of me to ask, but do you anticipate that, done poorly, MSK contributions could be a hindrance rather than a help? You know, if it might be coming from a good place, but fundamentally not coordinated well, or not been if you're not thoughtful, or there's not good expectation management over your skill set, actually we could contribute to this problem.
So if you have an MSK physio who has never been on a ward for 10 years, you know, and is thrown in there to treat acutely unwell patients, or patients who are in a very acute phase of their recovery, absolutely, that's not good. And nobody should ever really think about going down that line. And if you are, this is my personal opinion, if you are in that situation, you need to challenge back, but challenge back responsibly. You know, don't be shouty about it. Don't be, these people who are making decisions are doing it from a good place. They might be stressed, they might not be, you know, they might not have a level of experience. They might have no one that's got their backs. We're seeing HPs in certain trusts, not being at the table having these discussions. When we're involved and when we're at the table and when we're invited, we will be part of the pandemic planning. When we're not, it's a knee-jerk reaction. So, we're shutting the MSK department, send them to the respiratory ward, send them to the stroke ward. That is not planning. And it's part of our responsibility, and this is why this is great that you're doing this, Jack, because it can help prepare people. So if you're an MSK manager, or, you know, you're a senior clinician, find out what your contribution is going to be. Even go to the people that are making these decisions and say, look, this is what we've got. We've got the 6s that can do this. We've got the 7s that can do that. We'll do the 5s that can do that. If you've got techs in your department, what can they do? So take some responsibility for this. And if you don't like what you're hearing, rather than have the knee-jerk reaction or start getting shouty, actually sit down as an MSK professional and do.
I totally agree with that, and certainly, that's exactly where calm needs to prevail, and we need to be mature and very charitable to what might feel like a poor decision that's coming back to you. Needs to be sometimes, you know, played back, discussed. It certainly needs to. We need to make sure that we're all giving each other the space to make these decisions and make mistakes within these decisions, and trying to make sure that we put the safeguards in real time. One of the things that I've been thinking about more recently is that there's more obvious pressures on facilities, resources, staff, beds, etc., with regards to the critically unwell, but it's also an incredible stress test on the strategy and human resourcing side of this, and skill placement, as you've described it. And I think that's the bit where we need leaders to step up. We need distributed and appropriately what's the word? Delegation, appropriate delegation across the board, where people aren't being misplaced, mistreated, and then mismanaged, because, as you've described, there are mechanisms in which that can only add fuel to the fire. So definitely something that people can bear in mind, and that is independent of their professional stripes, really. So that's really valuable to go through. One of the things that, just to bring us to a bit of a close on that, I think, really, is to say, do you anticipate there being really specific, be the local or national policies that kind of will offer obvious clarity as to rights, responsibilities in these circumstances, or will there always need to be an overlay of individual professional responsibility? Where do you see that going in the coming weeks and months?
So do you mean just for the physiotherapy profession? Yeah,
so let's say yes, I don't mean social responsibility now. No, I do mean like physiotherapy profession across the board. Do you anticipate that like it will be clear as to what you are meant to do? And by that I also want to say, in terms of when you contract this, or you have a positive test, or what have you, or when we get into the deep of it, if it goes the way that things are in Italy, will there be that you are expected to report to work until you're symptomatic, or or do you think it'll be that you end up with this overarching individual overlay where you have to make individual professional decisions without there being a policy-informed responsibility?
I mean, that's a great question. The bottom line is, if you're infected, you stay away. You're absolutely right. There's stuff in the media, and even there's medical colleagues on social media who are saying that if the ball is being put in the individual's court, if they're a healthcare worker, about coming in when they have the virus. I think the bottom line for the NHS is that if you're a member of staff because obviously we're not testing everyone. So if you have COVID-19, you stay at home, you self-isolate 7 days, and then only come back if you're symptom-free. I can't ever imagine us not doing that. In terms of redeployment, are the MSK physiotherapy community in the NHS going to get redeployed? I mean, I can 100% say I honestly think they will, but it's within the right arena. And obviously we need to really look after our MSK physios. So in the same breath as I'm saying, are you the MSK manager? Are you the MSK team lead that doesn't really know what your inpatient staff do? You never really sit with your respiratory lead. You haven't got a Scooby-Doo about what goes on. Actually make the time, say, do you want to sit down? Have you had a cup of tea today? Have you had your lunch today? Do you want to sit down? How can I help? In the same vice versa, that means your respiratory or acute teams are going to look after your MSK staff and say, look, make sure you've had your fit test. This is what you want. This is how you put your personal protective equipment on. Let's plan before we even get to that stage where we're potentially putting our friends at risk.
Yeah, could we find a way for this to finally bridge the gap between the inpatient outpatient tribalism of old? Maybe this will bring us all together for some big kumbaya sing-songs in the months and years to come, because of course it's a crisis point and it needs to bring us together as a community to do our best for patients and to mitigate as best we can this pandemic. So thank you so much for your time. I know I've got you on the hook for a future episode of my new podcast for us to talk about all things Rachael Moses and the various different hats that you wear. So we've got more from Rachael to come, I can promise you that. Probably when the dust has settled from all of this. That might be a while yet, but I do want to make sure I've still got you on the hook for something like that. As well as thank you so much, and we will distribute the documents that you're preparing and sharing and the interpretations and translation material that you're doing. I know you're going to be doing some work with our friends over at Physiopedia as well in the coming days, so please everyone share that liberally. It's really important we get good information out there, and you are a font of that. So thank you so much for all that you're doing all of the time, but especially at the moment.
Thanks, Jack.
Nice one. Take care and good luck.
Thanks.
Ta-ra.
So that was the first chat I had with Rachael this week, recorded on the 14th of March, and a lot happened in the days after that, including 50,000 downloads as described. People found it very helpful, so add some meat to the bones of the conversation and detail some policy, including a call to action at the end. So we then recorded a follow-up on the 18th of March 2020, and this is how that went. I'll see you at the other side. I'm delighted once again to be here with Rachael Moses. We didn't expect that last Saturday, well, just a few days ago, we ended up doing a show-stopping 28-minute podcast that broke the internet. Only days later, 40,000 downloads later, we are inundated with requests for more Rachael Moses, and rightly so. And so here we are. We're going to add some meat to the bones of our conversation that we had. If you haven't listened to that yet, then please do. There will be a bit of overlap to set the scene, but fundamentally we're going to be adding some detail to that conversation. So please check the feeds and check social media for that conversation about COVID-19 and what physios should and shouldn't be doing about it. We have, as things have escalated in national policy, we've taken further precautions. Me and Rachael are over Skype, and we've washed our hands thoroughly. I am bare below the elbow, including not having any trousers on, and so I won't zoom out on the video. It is important that we reiterate some of the points on the last podcast, but above all else, the thing that seems to have really struck a chord is the pragmatic application of what MSK, orthopaedic, and other what I'm calling less medical physiotherapists and other MSK and associated therapists should and maybe could do in this crisis that we find ourselves in. Rachael is appropriately candid about
the upper limits of what might be competence or versatility of skill set, and is very sensible on those matters when others are sort of inferring that everyone can be everything. And I love that about her, and so I'm glad you guys all did too. So firstly, Rachel, thank you so much for coming back on the podcast.
Thank you, Jack.
So we're going to get stuck in, because we definitely want to talk a little bit about not necessarily policy developments in recent days, but certainly it's well worth us just clarifying some of the things that we're finding over COVID-19, and then we're going to sort of talk a little bit about just generally. It's going to be a lot about respiratory upskilling and where we should and shouldn't do it, which is not going to be specific to COVID-19 compared to our last podcast. So what do we know about the disease, and how is that relevant to the conversation we're going to have about what we should and shouldn't be doing?
So as we touched on in the first podcast, we talked a little bit about how this virus is manifested and what it's doing. So it's a virus that attacks the airway cells, and in varying forms. So we mentioned about 81% of people will have very mild or no symptoms. So some people won't even know really they've contracted the virus at all. Some people will just feel a bit fluey. Some people will feel really, really rubbish, but will be managed at home. And it's for them smaller populations of people that come in through the front door to the emergency department, normally after a week of having the virus, that they start to feel really unwell. And it's these people that present themselves that normally need frontline oxygen therapy. So these patients come in and they've got really low oxygen levels. And then, as I mentioned in the first podcast, is this even smaller population of people, say 5% of people, who become so unwell they need intensive care. And they need intensive care because they need intubated and ventilated and mechanically ventilated. So really, there's nothing in between that. There's, in terms of for physiotherapy, for front door respiratory physio, and we are world leaders in A&E and medical assessment units at the front door and respiratory physio in the UK. And I'm telling you, there's really not a role for us in that scenario.
That surprises a lot of people, and also should reassure quite a lot of people, which is great. And with regards to that, how much have you heard from people asking after respiratory competence upskilling, and what are the myths and misconceptions do you feel that we can add some detail to on this podcast?
So again, there's big variance in what we do in physio as an MSK, respiratory, neuro, across hospitals, trusts, and parts of the country. So if you have an A&E department that has a physio in their respiratory physio in their front line, and they're setting up ventilators and high flow oxygen and using adjuncts in the A&E department, I think it would be safe to say there might be a role for physios within that department, because they're doing that everyday role that they would do. And that's certainly true for some of the advanced practitioner roles that are in AD. For some of the myths that we're hearing about is upskilling large numbers of physios to work at the front door, to look after these patients and set up machines or do chest physiotherapy on them in A&E. That's just not going to happen. And one of the reasons why is for infection control, for minimising the amount of contact that people come into with healthcare professionals. We don't want people just to be mobilised to these areas, which are going to be high contact areas. We want to keep healthcare professionals at a minimum. So we want people to see patients at the front door who really know what they're doing across that whole patient pathway. Then obviously you have the 3 stages that I said that may come next. So straightforward, this person is really unwell. When people come into A&E with this disease, they're unwell, especially if they've got comorbidities. So they're going to be the ones going straight to intensive care to be intubated and ventilated, or be managed on non-invasive devices. So again, the respiratory physios that are going to be looking after these people who have years of experience, either working on call or being, that's their main specialities, that they're going to be the ones having contact with these patients, not an MSK physio that's done an online course for 4 hours and had, a couple of hours of training on the bird or whatever.
People think too much of me and you, don't need to think that we could even do half of what is being asked of us. Like, why don't you do a podcast on? And then the insert that into that space is usually something that's essentially akin to an ANP master's module that they want to do on an hour's podcast. So that's hilarious. So instead, what I think we need to try and cement there is that what this disease is going to do it's going to overwhelm to some extent, hopefully not completely, but really take up a lot of resources and a lot of specialist human resources in respiratory, not just physio, but respiratory care. So then a lot of the other stuff that we already know is stretching the service anyway prior to the pandemic ends up being something that we need to try and work out who is best placed to sort that stuff out, rather than thinking about what utility people have in the wider healthcare environment to solve the disease. Instead, we need to start thinking what is the competence that can work on some of the, shall we say, displaced, I don't think that's the right word, but I think people will get what I mean, the other needs that the service, the health service has. And I think that is really important, that we're almost starting that podcast off with that. So this podcast ends up not being about COVID-19, does it? It becomes about what the sensible things are in and out of scope, and where people can best place their skill set, because the COVID-19 question ends up being not one for MSK and orthopaedic physios, unless they happen to be an incredibly polymathic person that can suddenly flex into their skill set that's really versatile. But I've never met that person. So instead, let's think sensibly about what should and shouldn't be in scope. So I want to ask you that directly then. What things, can we give some examples then of perhaps what should be in and out of scope? Let's do the out of scope stuff first. What should MSK physios stay away from?
Basically, so I love my MSK physios, right? Just get that out there now. So I lead a service. I'm a major trauma teaching hospital, multi-speciality, specialist commissioned respiratory services. I do not want any MSK physios in my emergency department. I do not want them in my intensive care unit, and I probably don't want them on my specialist respiratory wards either. What I want in my emergency department, in my intensive care unit, on my specialist respiratory wards are competent, skilled staff who have had additional training to meet the pandemic crisis needs. That's going to be upskilling them in things they might not normally do, non-invasive ventilation, certain techniques that we might use, to help in that recovery phase. That's what I'm concentrating on now. The second wave of that is all of the other stuff these physios done, because they won't all be in respiratory. They might be in neurosurgery, they might be in pediatrics, they might be in neurology. I'm going to suck all of that resource out of those teams, and I'm going to need that replaced, because if we don't, we're not going to have flow through the hospital. So I don't want any MSK physio in my trust anywhere near, and I bet you bottom dollar my lot are probably quite relieved about that.
And I think a lot of our listeners will be, but there's almost a sort of, I get it, it's an obligation to sort of try and think in that direction, to sort of look back into old notes and old habits and think, what could we do? So in that sense, let's make sure we're really clear on this then. We are not going to be in a situation where we have the luxury of competency assessments and the personnel that would normally do that, even if that was a sensible thing to do, even in peacetime, let's say. Mm-hmm. So should people therefore, and this is where me and you have been fielding questions like this all this week, isn't it? Should people stretch their skill set even if they're rusty, or should they err on the side of caution? I think I know the answer to that, but let's just make sure we're really clear on it.
In terms of, should MSK physios be spending time looking through respiratory textbooks, writing down your blood gases and your normal saturations? Absolutely not. I think what would be beneficial if there are no indicators, so if they're going to see a patient, then know what the signs are. So if they're working a bit hard, if they look a bit uncomfortable, if their respiratory rate's a bit high, but that's just common sense, isn't it? I mean, isn't it? Have you guys still got common sense?
You do.
Are you so specialist you can't, spot someone that's maybe a little bit out of puff? I think so. Would I, if people want to, and I think there's two groups of people here. There's the panic people, the people that think, oh my God, I'm gonna get this call and I'm gonna be sent to an intensive care unit. I can't speak for the whole of the NHS. I'm just me, but I'm happy to say on camera that any leader that does that, wants to deploy staff into that situation, is just foolish. Do I think you've got the other people, the MSK people, who think this is a respiratory pandemic, I want to learn a little bit, I want to go reference points to when I was a student or qualified, and we'll have people that have been qualified 5 years who might think, oh, I remember a bit of that, 10 years, 15, 20 years and above, who probably, can't really remember much. But I bet you there's a lot of skills that you have in MSK that you probably don't realise in respiratory. I bet you there's loads of things you can do with shortness of breath, positions of comfort, positions of ease, relaxation, kind of normal movement patterns that you already know. And it's maybe until you see a patient in front of you, because that's the biggest thing for me. You guys being on a ward with a patient who can't, catch their breath, maybe in their pajamas. Like, how many of you have been in that situation for maybe many years? So, my advice would be to maybe think about that side of it rather than, interpreting a chest x-ray. Like, can you teach us how to interpret x-rays? It took me 10 years to learn that.
Oh, I know. And this is what's funny, is that people aren't meaning it, but there is some disrespect that comes for the ride when people are asking questions like that. And I think I beg my MSK, orthopaedic and surrounding, sector to consider the flip side of that and consider how ridiculous it would be for us to be asked that question. What could me, a 15 years of respiratory physio, do to suddenly upskill a full body MSK assessments for job logs in the waiting room with persistent pain? That's a ridiculous question. We'd know that. Yet there's people saying, could you provide two 15-minute videos that might answer that question? So we're reframing it, and we're hopefully being reassuring to say that is silly. Let's explain. Let's understand why that's silly. Let's also understand why people are thinking that way, and it's out of compassion. But even though it's sometimes a bit of a cliche, and some people are joking, some people aren't joking, put your stethoscopes away. That's not smart unless you know how to use them. And are there, I suppose, instead of me reeling through them, are there things like that are examples of where we can be really crystal clear? Like, for example, that as one thing, and other specific respiratory skills that they shouldn't be trying to flex into. Are there other examples of that can be clear that they shouldn't be doing?
Yeah, I mean, these people are sick people that are coming into the hospital. They are sick, they are unwell. If they've been on intensive care, they've needed full-on organ support. Are we seriously, as a profession, thinking about mobilising a workforce to those patients who have been critically unwell in those stages? So absolutely, like I said, all I can do is speak for me and my team and what we're doing. I've absolutely had the same conversations that you've had about saying, we're going to upskill these staff. We're going to do some respiratory training with them to get them on the wards and to look, I think there's awareness training, which I commend the MSK population for. I think that's what you're saying, isn't it? If you want to upskill yourself on awareness for what patients being a bit short of breath, what you can do, but actually what you as MSK physios can do within your skills, not learning new skills. That's not going to work. Well, this could happen tomorrow. It could happen in 2 days' time. Yeah. We've got to just forget about thinking about skilling people up and sitting in a gym, training sessions in gyms, with no real people, with mannequins at the best of it. What are people thinking? They're going to put MP suctions in and things like that. Like that is just no. Well, we need to stop it.
People are thinking that, and they're also then sometimes thinking, not only can we do this incredible task of upskilling, but can we do it virtually? That's the other thing. People are realising that's not an in-service training that should happen in person right now. So let's get serious and understand why people are feeling like that. But let's put that to bed, and hopefully this does that. Now, so of course, this is Jack and Rachel's opinion on that matter pragmatically, and others might disagree, and we look forward to hearing from them. But in this instance, that's a strong opinion of ours, and we think that is a simpler answer, because instead we can spend the rest of this podcast thinking about the practicality of what we can do. Now, there's an interface between those things, which is awareness, which we definitely want to cover and is a more reasonable question. So let's think about some of that then. As MSK, orthopaedic, and what I'm calling less medical therapists, as we help with rehab, so things that we talked about on the last podcast, what can MSK therapists do? People loved that idea. We're going to be doing the rehab, seeing potentially people that have been more ill than we might have otherwise seen them, but fundamentally using functional MSK skill. So when we're doing that, what signs and symptoms should we be mindful of? You've mentioned some already, and then what are the sort of red lines for then seeking more specialist help when we start to notice those, like what might be signs of regression, etc. So let's think about that interface.
That's a really great point. So we're going to we don't know at the moment. This disease took a hold at the end of January, right? Yeah. So in terms of post-ICU syndrome, in terms of pain down the line, neuropathic problems, especially because we know it's affecting mainly the older, frailer population. So if they do survive this critical illness phase, there's potential for huge musculoskeletal problems down the line. Okay, so that's the first thing. We just don't know what the long-term effects of this. If we categorise this answer into two sections, so COVID-19 patients, if you are seeing them in that recovery phase, then they've had a bad ARDS, what we'll call acute respiratory distress syndrome. Yeah. It's an acute lung injury to the point they need ventilation. So the lungs are going to take time to recover, might be a bit short of breath. They won't have the reserves. There might be, difficulty even talking. So the activities that you're doing with them might be in the bed, it might be breathing control, it might be active cycle breathing techniques. And you might think, Jesus, do they still do that? But we do, and it really works with some patients because it helps to get their breathing control so they can partake in more exercise and be more mobile. You might have people that you're being asked to see that are still in oxygen therapy. So we are anticipating discharging more people with oxygen therapy to get them home if their lungs have been particularly damaged in that acute phase. So it might be things like moving people and immobilizing people on oxygen therapy. When do you know when to stop? What is that threshold? And again, for me, it's a common sense approach. If they can say a couple of words and they can, they look comfortable, keep walking them. If not, and they can't get any words out at all, you push them too far, sit them down. This is the type of things we're talking about that we'll be expecting of our MSK workforce.
Yeah, of course. No, that makes a lot of sense. And as you say, common sense is all well and good, and it's all about trying to have some composure in those situations as well, though, isn't it? So I'm not underestimating the fact that it's easy for me to sit here. I'm not meaning to sort of arrogantly scoff at the idea that might be challenging. In real time, I would be struggling to find the composure to sort of think about what is in front of me, even though it might be common sense. So that's a really, really good point. With regards to some, I think you're right. We sort of said about ABGs and stuff would probably be something that would be silly for us to be over considering, especially when these are then rehab patients that are otherwise we're trying to make them well or they're becoming more well. But OBS would be smart, wouldn't it, for us to keep an eye on, and certainly within what should be a skill set. So then we think about OBS and we think about worker breathing and we think about oxygen need. That's the sort of common sense we're thinking then, isn't it? What is the change in behaviour? Making sure we're thoroughly reassessing patients in that. So what clues might those sorts of things give us?
So your subjective assessment is really important. So looking at the patient, talking to the patient, you can even use things like visual analog scales if you want to say how breathless are you right now on a scale of 0 to 10, how much pain are you in, and then doing heart rate, saturation. Most people will have, obviously, they're just the plain SATs probe you can put on the finger. And if people have, if there's an indication, doing things like blood pressure. So they would kind of be the things that we wouldn't expect people to do anything more than that. And these are things like if our students are on placement, our students would be doing that. Yeah. Our therapy technicians would be doing that. These are things that, are totally within your realm to do. Does that answer your question?
Absolutely does, yeah. It started to, when I've started thinking about this and started preparing not just for this podcast, but trying to field some of these questions and thinking, part of me just stop it hovering over the button where I was about to forward it to Rachel and thought, no, I am not overwhelming Rachel with these questions. I asked her some of them on the podcast, let me try and work it out. Is that I was reflecting on some work I did within a hospice that was incredibly powerful work early in my career that's really laid the scenes for why I'm so passionate about functional rehab being such a bridge between all of our disciplines. A drum that I've banged across it being like this bridge factor for respiratory and MSK and stuff like that is because the functional rehab needs and the value you can add for someone to be able to stand up so that their carer doesn't have to lift them up is just massive in end of life care in a hospice. So if people start thinking about that and start thinking about what it is that you can do to not just from what you find on assessment, but the value you can add to someone's life in that moment in time, regardless of their specific goals, even if it is something to be able to manage one sit to stand every couple of hours to assist their carer on changing, that is incredible. So then, of course, everything scales up from that in terms of getting people home, getting people back active. So that's where MSK physios need to start really thinking about what are you assessing, and then just how much value you can add to some of the things that we want to talk about now in terms of what might be the realistic needs really for MSK physios to apply those skill sets in a rehab environment. I definitely want to just add a little bit more to understanding how we might measure that, because I think we can speak to common sense and that's great, but I do want to just make sure we don't miss opportunities to potentially make sure we measure it, because it's one of them things that's easier to do. It's easier to apply common sense if you've got some continuity of care. And MSK physios are quite used to that sometimes. We manage to retain our own caseload. And I know that's done in inpatients too, but especially when people move wards, etc. I know it's a bit different depending on the governance structures around that journey. And so we don't want MSK physios to be complacent on that. So let's think about sort of what should be measured and documented appropriately. So as people become functionally less functionally limited, less unsafe, but more functionally limited, what respiratory factors should we be considering and measuring in the community and outpatient clinics as they develop?
In the community and outpatients?
So yeah, as people start to be functionally limited, once patients are safe but still functionally limited, what respiratory factors should we be maybe measuring? And are there any evidence-based outcome measures in, say, the community that if MSK physios and the like, or therapists generally, are going to see them, is there anything there that's specific that we might not typically do that we should be doing in terms of outcome measures?
That's a great question. So long-term community follow-up probably isn't my bag. Most of my patients can't breathe. But we'll obviously have like pulmonary rehab type things like the 6-minute walk test and probably like the St. George's respiratory questionnaire or something, which is a subjective test. So is there any functional outcome measures that would spring straight into my mind for this population of patients? Well, the first thing is we don't know what this population of patients are. We are dealing with a new pandemic crisis right now. So these patients are stable. They're going to have to get out of hospital. We want them out of hospital while making way for the next patients to come through. So we're probably going to be discharging people functionally less able. We're going to be discharging people probably fatigued. I don't know if you've ever had the flu. I've never had the flu. Apparently it's pretty bad. You feel bad for weeks if you've got comorbidities, etc.
I've had man flu, which is obviously far worse.
So this population of people are still going to need recovery. You're absolutely right. So we're going to be discharging all these people that probably have a high readmission rate, that probably may drain your society, your resources. When you get back up and running, you're potentially going to have all of these people with joint problems and back problems and, musculoskeletal weakness. So, how can we manage that? Where's the opportunity there?
Well, and that's where I definitely wanted to talk to you about let's try to speculate and assume and try and get ahead of something, or at least get people thinking in this direction. Because me and you have been talking about this off air. We're thinking in this direction. Even if we're wrong, it's still a worthwhile thought experiment, isn't it? If elective orthopedics are being cancelled, if your routine OA knees or your grumbly sports conditions that someone's been meaning to get checked out for 6 months and eventually get round to doing it, if they're not coming into clinic for a period of time, then and MSK therapists are wanting to do what they want to do, and they're listening to what we're advising, that they lean into their skill set rather than do this sort of abstract upskilling into acute medical skills, then there is surely a sensible experiment that should be done, a pilot of a sorts that then deploys those specialist MSK therapists into functional rehabilitation care in the community, which is not group-based, especially in this moment in time, but is essentially just applied functional scaling of that person's individual needs wherever, in whichever environment is relevant to them, be that home or elsewhere. Now, if ever there was a time, I mean, I think me and you would be in favour of that, why are those pilots not being done, right? But if we can't take this opportunity to demonstrate the value of that as a means of then showing the bridge that I was talking about earlier between our disciplines, this has got to be the moment, hasn't it?
Oh, literally, like, my juices are flowing right now, Jack. Like, that is so exciting. So can you imagine, right, we are achieving things in the NHS in the space of days that we've been trying to achieve for years, right, decades. Can you imagine if, as a result, let's try and think of some positives, as a result of this, as a result of culling all non-essential MSK services, orthopedic surgeons, which is bad, you know, there's people that need operations and things, but if we have this highly skilled musculoskeletal professional kind of people that are just at our disposal, and if you mobilize them into the community, so this might be to, you know, if we've took, say, resource out of rehabilitation beds, etc., you mobilize them into them facilities, or you mobilize them into the community, that is going to have a massive impact on these people. So we're going to be discharging people less functionally able, like I said, who maybe are frail, who maybe have these musculoskeletal comorbidities. And if you have a workforce that's ready to go to meet the needs then, not in 6-week waiting list, not in 12-week waiting list, at that moment in time to prevent further decline and functional decline, that is just incredible. Can you imagine the impact for our society and getting people back to work when people can't go back to work, the bigger healthcare economy around that?
Well, and that's the bridge to the economics of this, is that the recovery effort that would occur by facilitating sensible occupational health principles of graded return, and having specialists that can facilitate that, and a process of consultation that lends itself so well to virtual. You know, that there's almost a coaching aspect on practical levels, the liaison to workforce managers across various different sectors, the ability of therapists under new fit note schemes and stuff like that that are still creaking into gear, right? So this is the opportunity to grab that chance. Now, when it comes to workforce stuff, this is one of the things I really wanted to talk to you about. I'm fielding calls this week already, but also I've got a couple tomorrow, so I don't know exactly how they're going to go, but really proactive groups of osteopaths and charities of various different flavours in MSK and beyond, of multidisciplinary therapies, sports rehabilitators, sports therapists, that are in a situation where they want to offer help and are, I think they don't have that same, some of the MSK physios sort of have this sort of seeming, they're the ones that are thinking they need to go and dust off their stethoscope. The osteopaths and stuff and the sports rehabbers, they haven't got those instincts because they didn't necessarily train into that skill set. So instead, they are already sort of thinking about those functional rehab stuff that we're talking about, but there's also a barrier to entry to some extent within the NHS. Right? They have difficulties being employed beyond Band 4 sometimes. Slightly different with osteo, but still they end up often working in and around different roles to what MSK physios do. So that workforce is broad and it's multidisciplinary, and there's a really rich skill set that the NHS underutilises anyway. Now, admittedly, I'm speaking into an MSKR policy here, where we've made a case for a broadening of that workforce, at least on a pilot, for not caring the flavour of the certificate that's on your wall. Now, again, with sensible leadership comes competence-based recruitment into those sorts of roles. surely we use this as an opportunity to demonstrate that value within populations that just have rehab needs that are quite generic, where you need to scale their function from where they are to where they want to get to, and it's not necessarily anything that's especially pathology specific. There isn't as much of a diagnostic need. It's kind of that frailty based approach, but also recognizing that we've got a weak and vulnerable work, that they're not necessarily even frail or pre-frail, and they're not even age risk factors there. It's just that they've been run down by an illness, and we need to get them out of the system quicker, into the community quicker. Those are the sorts of people, therapists that we need in front of them, right? So do you think that, we're both excited by it, but do you think it's a pipe
Clearly.
dream? Right? Yeah, but do you think it's a pipe dream? Or do you think that this is there is going to be the political will to make that happen?
So instead of this MSK amazing workforce trying to create their respiratory pocket notebooks, if the MSK workforce was to sit down and come up within their organisations or within their population, so working across the strategic networks or wherever they're working, you're going to have MSK who are already in the community and GP surgeries. Because that's another thing, Jack. The GP surgeries are shutting, aren't they? I mean, I've heard that surgeries are closing. I don't know if it's happening on mass scale. I haven't had the time to look into it, but who's going to be treating all these people that come in with the MSK type problems? So if we have a referral system from the hospital, so the discharge referral system, into this new collaborative community physiotherapy-led initiative, the COVID initiative, the COVID rehab initiative, I don't know what you can coin it as, and then they take a lead on that and they say, look, we're going to create these discharge pathways. We're going to create it in my locality, how it might work. We're going to see these people in the home environment. And don't get me wrong, you can't just put a physio in someone's house and it's going to happen. There's going to be infection protection control issues. We don't know how long these patients have a viral load for. We don't know how long their infective period is. We're in terms of discharge planning for them. So there's going to be all them types of little things to work out. But in terms of the government planning, we're not talking weeks, aren't we? We're talking months. So the post-viral recovery phase is weeks and months. So we'll have a bit of time to get this right here. So is this my take or my question back to you guys is, I'm doing my bit. I'm mobilising my staff. I'm creating a specialist workforce to help my intensive care units and my respiratory wards. With that kind of prod, can you guys step up and create these we've got such good initiatives, right to rehab matters, like there's really good, the CSP provided a little platform for you here, haven't they, to think actually there is a policy around this.
Absolutely. No, it's primed for use. Absolutely. One of the things that tickles me a little bit about that is hopefully, I mean, this won't do all of that work, so unfortunately you will still get pestered. But you should surely, if anyone listens to these arguments and doesn't, if someone counters them with better arguments, then fine. But if people are going to universally agree with us, because we've really done the thinking on this, let's hope that they do, that people should be leaving you alone with those questions and starting to then think that let's get organised, let's think strategically, let's take some leadership both as a profession and as organisations to try to then work out how to unify that. What are the parameters, the competency parameters around what an MSK workforce can do? How do we make sure that we just park the petty squabbles, the 20% we disagree on, how much we lay our hands, how much manual therapy matters, how much, exactly how much we should load a tendon, right? Let's park those things that are fun academic things that we've squabbled on before in peacetime and start to think about what unifies us and start leaving you and your specialist colleagues alone a little bit. So how can we bring that together? I would definitely, it's exactly the conversations I've been having all week and some of last week. It's the conversations that I want to try and make sure that this platform and all of what we do with Physio Matters, but of course now with the sort of activist arm of it, which is now into MSKR, of course we can help with that, but only, we're just floating policy. Essentially, we want to work with the CSP, feed into that right to rehab, help people comprehend their role within it, make sure there's no barriers to entry for those sensible, evidence-informed osteopaths and sports rehabbers and stuff that want to get involved in that conversation. Surely this is the opportunity to make that happen and make sure that there's no silly protectionism that goes on professional boundaries, which makes you sensibly less relevant to this conversation. Do you know what I mean? It's like you can get on with doing what you do and stop being pestered by the likes of us. So that's probably the smart move, and definitely something that we need to see decent leadership emerge from where is appropriate, and where people are well placed. And if people want to be nerdy about it, the macroeconomic situation as we see it, and the amount of public sector jobs, the modified socialist economy that we're probably going to need to have, which is sort of what happened in a post-war period, is going to be that surely those are the sorts of public sector jobs that would be wise to employ healthcare professionals into. And then if that proves concept, then surely when the dust settles on this in 12 to 18 months, probably at the shortest, then surely that's a demonstrable blurring of the lines between professional boundaries, and then we suddenly just care about individual and group competence, don't we?
Absolutely. And I think I just need to probably go back a step and reiterate, because I can sense some people maybe getting a bit twitchy about this, therapy managers and things saying, oh God, we're scaling up our workforce and we're using these MSK physios to do everything that she said not to do. You're going to have variance within your MSK departments, aren't you? You're going to have band 5s, you're going to have your 6s with still some skills. I want to use those physios in my wards. I want to use them. Okay, so I'm not saying I don't want to not use skilled with the right skills. This is a real opportunity. So, we mentioned, I can't remember exactly the comment I meant about this clinical specialist, the ESPs. They've probably got the least skills when it comes to transferable skills into acute. But, what an opportunity for these guys. I know some of your friends and things, and they're really savvy people when it comes to media, when it comes to just getting on and do it. Let's just do it. Well, now it's an opportunity for these people to put their money where their mouth is, isn't it? Because this is a bloody good idea.
Yeah,
so
absolutely.
How can we mobilise this, and how can we use our networks and our links to make this happen? Because as someone who doesn't want these patients coming back in the hospital, we don't want them having falls in the community. We don't want them picking up secondary infections or sitting in their house. These patients are probably going to have some kind of post-traumatic distress. Can you imagine waking up on an intensive care unit and being told you've got COVID-19 with people in hoods and masks, and then you're feeling so lousy, not being able to see your family and friends? So therapists, we're all going to this profession for the same reason, don't we? Especially in the UK. And we are still going to have those underlying skills as well, caring, compassionate, understanding in that recovery phase. So it's not, I think sometimes we focus on the therapeutic hands-on stuff, don't we? What impact can we have? But these are people. It could be your spouse, it could be your parent, your brother, your uncle, it could be anyone you know. So you would want that. You would want that person, wouldn't you, in that recovery phase?
Well, and we definitely need to just make sure that we clarify that point as to what levels of, because me and you are getting enthused by the policy, but the reason we're enthused by it is because the social impact of getting that right is so huge, because we need people that are highly skilled in empathy-based communication are going to be the ones that can help us recover this as a society in a world where people are going to be waking up, as you described it, and recovering in a world where they're not allowed to see their dying relatives, or not supposed to see their dying relatives. In Italy, they're banning funerals, right?
Yeah.
So we're in a situation where the world as we know it, and the processes of grief, the way that we would care for our sick relatives, the people in their 60s that would normally be looking after their parents who are in their 80s and 90s, are then being told to stay away from, even though the likelihood is, based on statistics, that there's a chance of them not not surviving, yet they've got to self-isolate. The psychological distress that we're going to need to be trying to help people through, as well as what we're all going to be going through as people as well as therapists. This is why, whilst the giddiness that we've just had 10 minutes on between us in terms of policy is purely because of our knowledge of the impact done well that this could have at a time where they're the specialists we need, right? The people that can really understand empathetic communication, that can really understand the pettiness of the intricacies of where we academically might squabble before, and to realise the unification that can happen around the real priorities that that the massive social triage that we're going to do over what is of high value and what is of moderate value. And that's what's a massive importance. So if you've not realised already, me and Rachel and many others, of course, just want MSK leaders or people that are otherwise coherent on strategy to start thinking in that direction rather than thinking about the stuff that we covered at the start of the podcast. Because if your skill set is in man management, if your skill set is in networking and bringing together groups, if you have tried to build bridges before that have never come together, maybe this is the chance to try that again, to pool resources and pool names, to dust off the black books and try to realise that they're putting people together that communication might have broken down before. It's a different landscape, and the rewards for getting that right this time are enormous. And so let's do that. Obviously, there's people like us that are just in that sort of like new media landscape that, of course, can hopefully try to, this is exactly what we're doing to try and bring that together. But above all else, just that's, sometimes it takes for some swallowing of pride to go on. Self-interest needs to certainly evaporate and realise this sort of collective effort that we all need to employ.
Absolutely. I couldn't agree more. So I think this kind of has gone back to the original point, wasn't it? Is MSK Physios, what is your unique contribution here? What is it? I'm fortunate in some ways because I have a skill set that is needed. My profession, it's obvious what we're going to do. It's obvious where our upskill needs to be and how we're deployed. We've got that middle bit we talked about, maybe the rotational staff, the people who have acute skills that can do all of the usual NHS activities still have to happen. Okay, we're still, like we said, we're still going to have that population of people. It's not just about these post-viral patients. But these are a new population, what we don't know what to do with, but we've got to get it right because the NHS won't cope if we don't, because we are already overwhelmed with our existing clients. So this is why, for me, this is so exciting, and I hadn't even thought about it till we were having the conversation. Like, is this your unique opportunity? And your strategic leaders in MSK, the people in the leadership posts, the people like yourself who are channeling, good practice. What is rational? It's not about what is sexy. It's not about what attracts the most attention. It's about what does a population of people need in our healthcare. And that is a massive contribution to society. And that makes me feel, so overwhelmed with happiness that you guys are even thinking about that. The fact that you want to know about respiratory stuff is absolutely commendable. Like, I love yous even more. But is it necessary? Well, thank you so much, but I really don't think it is. But I think this is.
Well,
I think everything we just talked about is.
We get the instinct, don't we? Like, we understand why there's that instinct, but we just think it might be misplaced. And if you channel that energy, I mean, if you think about the ambition that therapists and groups of therapists that are approaching you and I about that stuff that's a mountain to climb, that they're saying we're willing to climb it, help us climb it. I'm reassured that we're saying, instead of, right, here's the mountaineering equipment to climb that mountain, here I am exhausting this metaphor, instead we're saying, no, you've actually got a lot more you can do here on base camp. There's lots more you can do here, and that is hopefully a reassuring message that they can double down on some of these things and think strategically about what that's going to look at, not just now but down the line. I want to just give a couple of examples here into my niche area with regards to within MSK, particularly when we're going to be doing virtual consults. So I want to just say to my colleagues in MSK, think about the importance of getting a quality clinician in front of someone who has just sprained their ankle that would normally wonder whether or not to have an x-ray, that then consults you virtually through the NHS or privately. And the difference between you and Joe Blogg's cowboy down the road, and you're going to go through trying to do a virtual version of an Ottawa ankle rules. You're going to be trying to be sensible and evidence-based about whether or not it's what the likelihood ratios are of that person having had a fracture and how that might be managed, and understanding that pathway. When cowboy down the road is trying to do a virtual consultation, they would normally try and rub it better, put some acupuncture needles in and a magic machine, right? They're the ones that might be doing that, and they might say, better be safe than sorry, you want an x-ray for that, and send that person needlessly into a healthcare system that's stretched. Whereas you, as a quality clinician, are being thoughtful about it. We need to get you in front of people, ideally virtually, I would say, in this instance. Similarly, there's absolutely no reason why we're going to have a decreased rate of cauda equina syndrome suddenly in the low back pain population, and we know those percentages. We've exhausted that on this podcast recently. So we need you as a quality clinician to be triaging that and helping someone to we already have complacency rates within cauda equina where people don't want to go to A&E when they should be doing. So imagine just how much that's going to be accentuated by people not wanting to stress the system. Joe Bloggs in the population, not a therapist Joe Bloggs, I've got too many Joe Bloggses in this example now, haven't I? But a patient in the population that's got a back issue that we know to be cauda equina positive on the questioning is going to be in a situation where we already know they don't take themselves to A&E with enough urgency. For no fault of theirs, they're going to be even more reluctant to do so. So they might consult you virtually, and we want them to see the Physio Matters podcast listeners, not the masseuse I've just described who pretends to be a physio, right? So these are the sorts of things that even without the more grandiose examples of policy escalation that we've talked about with regards to rehabbing workforce, but even just on a basic consultation level, MSK physios step up, and also, I hope, don't be shy and don't succumb to what I call professional correctness, which is where you have a go at me for inferring that cowboy exists, right? I get a lot of trouble for suggesting that there is an unscrupulous physio around the corner. Get over yourselves. This is not a time for purity tests. And dust yourself down and be the best clinician you can be, and inspire good clinicians to do good consults, because everything else is happening behind the scenes and we need to be there for when the system grinds back into gear. So those are examples that I want my MSK colleagues to step up to. And if we've made the argument where you can stop thinking about where your stethoscope is and start mobilizing your thoughts instead in this direction, stop bothering Rachael and her colleagues in that way, and instead start thinking about that. I'm excited to see if the people that love to talk about hashtag leadership and start to pat each other on the back about how well they've done for all that sort of gubbins and garbage that sometimes happens where it just becomes a sycophantic backpatting exercise. Let's see if some actual leaders emerge rather than get appointed. I'm really excited to see if that happens, and I hope it does. I hope this inspires that and people dust themselves down. But realistically, the opportunity is here and the rewards are enormous, not just for the profession but for society at large, because compared to most people that are feeling powerless in various different industries that of course have got incredible social value, hospitality industries, etc., they're feeling powerless. We needn't feel as useless as we feel right now. Let's step up and make ourselves count and make a difference. So, with what you're doing, if you can just trailblaze the leadership that you're showing, the projection of resources, the pragmatic translation of resources that you're doing, if people can do even half a job of what you're doing, then we'll be in a better place. So, again, I know I'm ranting now, aren't I? But thank you so much for your place in this, and I hope we can appropriately refine your place in this so that you can continue to be efficient rather than having your time wasted by well-meaning but misled people and misguided people, let's say, and hopefully reassure some service managers that they don't need to give themselves quite the headaches that they have been over the last couple of weeks.
That is such a great point to start wrapping up on. So if you're watching this as the physio manager or the AHP lead, I'm probably pissed off a lot of people in my profession on this podcast right now. They're like, what the hell is she doing? This is what we normally do. We normally want to get as many people as we can on awards. Well, I'm sorry if I pissed you off, but this is what I think. So if you're the physio manager, if you're the HP leader and you've watched this and you go to your MSK teams and say, you know what it is, I listened to that Rachael Moses on that podcast and we're not going to put you on the wards and you don't have to get your stethoscope out. I don't think there'll be one person that thinks, oh God, I really wanted to do that. If they go to them and say, let's think about what we can do, bridging our services, helping with the rehabilitation, everything you've just said there, Jack, I won't repeat it. Can you imagine that's going to inspire people? That's going to motivate people. People are going to want to support the healthcare. So I think that's a big take-home message, and that's what you were trying to do from the very beginning, if I've got it right.
Mm-hmm. Well, yeah, and then that's why I'm cautious and why I'm inviting people to disagree with us, because I always worry that it might look like opportunism, that this is a thought process, a thought experiment that we've been doing and floating for a while. So I don't want to look like an opportunist to just say, oh well, look, we're just shoehorning in what we think is our favourite flavour of policy. It is an opportunity that I feel is knocking, but it's only because I really genuinely feel that this has only strengthened those arguments. Now, if there's a counter argument I'm missing, I'm really interested to hear it. I look forward to hearing from some of yours and my colleagues that disagree with that practical aspect and the fact that they think that the MSK workforce actually it's not as big a step as we're suggesting for them to start to understand non-invasive. I can't even say it. Never mind use it. Non-invasive ventilation. If they think that we're being too flippant on that, then please, we want to hear from you, because we want to understand the strength of your argument. We clearly disagree with it. It's not through lack of thinking about it, and you can look back on our channels and find an interview at Physio UK like 3 years ago where me and Rachel talked about this very stuff, right? So we've been pretty consistent, and we've not had an argument to change his mind on this, but we'll probably link to that. That'd be quite amusing, actually. But if you disagree, then please do. We are not being cavalier on this. We've given it a lot of thought over many years, and we think it's very applicable now, and it's very important that we speak our mind on it, even though we admit and we understand it's controversial. But we are not doing this to scaremonger. We're also not doing it to be sensationalist. Oh, that's not even a word, is it? Another edit point. Is it?
I think so.
But we are not sensationalising this for the sake of it. But we just think it's important. We're very passionate about it. We see an opportunity knocking, but we also see that if we get it right, I don't think it's dramatic to say that we could really help the war effort on this. And getting it wrong, we could at least be net neutral would be a good thing. We could actually confuse matters if we did it wrong. So let's hope that people dust themselves down and get their channel their well-meaning attention in the right way. Because that's one thing that's been consistent, is that people are really caring about this stuff, and that even though we think they might be sometimes misplacing that application, that's still a good place. We'd rather people doing that than just being sort of passive or apathetic. We've not seen any of that, have we? We've seen passion. Let's place that passion sensibly, and we could work wonders. I doubt this is the last time me and you speak about this. Certainly off air, but on the air, I think we've hopefully tied a bow in it and helped that you get on with the important work you're doing. Is there anything else you want to add as we wrap up, and where can people find you?
In this office or on the wards. Obviously, I'm more than happy if people have me email details. I'm on Twitter. That's my main social media channel. Just please take everything on board. Thank you so much. As a profession, how amazing are us? We're coming together in a time of crisis to really want to have a contribution to the crisis and to healthcare. So thanks so much, Jack. Thanks to you for doing this. I mean, God, you've had a really huge response. All of it's been positive. Me DMs have been binging away. Thanks so much. And honestly, if you guys want any help, it's strategically trying to work out what the next step is, and more than happy to do that. But I'm sure you've got enough leaders within your profession to do that.
No, well, here's hoping, as we say, that leaders do step up. I mean, we're just hopefully providing a megaphone. The opportunity is not for us to just say, look, all the stuff we've been doing, as I say, squabbling over exactly how to load a tendon and whether how much you should apply manual therapy. The fact that we've just built a channel that can help us amplify messages like this that are far more important than those things is just a great privilege for me to be able to do. And thanks to my team working behind the scenes to coordinate this podcast. Huge thanks to the sponsor of this podcast as well, the Royal National Orthopaedic Hospital, the charity at that hospital that's wanted to try and amplify this message and helped us to bring this podcast forward in the schedule, for you finding the time for us another evening in the same week because of the public response to what we've found in the tens of thousands. It's exciting and it's really important, and I don't want you to underestimate, as you continue to do, your important voice in this, and as the response has shown, I hope that's making you realise just how valuable that is, and your bravery to go against the grain sometimes to at least speak your mind is really fantastic. So thank you so much for that personally.
And that was our first emergency COVID-19 session. Thank you so much to Rachael Moses for that. Founder at Rachael Moses on Twitter, where she's very active at the moment, helping with all these questions. As I mentioned in the intro, the most important thing for you to do right now, if you're interested in what we've been discussing, you want further information about how you can help and at least not be a hindrance, then please go to mskreform.org.uk/rehab recruits. We put this out very shortly before this podcast was out. We're already getting hundreds of people volunteering into what we think will end up being a mailing list that we'll be able to hand over to the Department of Health and NHS England, Wales, Scotland, Northern Ireland. And we're really excited to be able to try and bring that together and channel this effort into community rehabilitation and really utilise people's specialty as best possible. So do tune in for future emergency sessions as well as other work that we've got going on. This is the time to follow us on social media at TPM Podcast on Twitter and Instagram. Find us at the Physio Matters Podcast on Facebook, YouTube and beyond. So please do follow all of my team and thank them so much for all of their hard work that they're doing at the moment to really keep the messages flowing to you guys, and hopefully we're able to stand up and be a voice that's helpful and megaphone for good ideas in this important time. So thank you very much, take care and do look after yourselves.
So you've been listening to the Physio Matters podcast, discussing physio matters because physio matters.
Brilliant. Love it. Cheese galore.
That's from a fucking cheese.
Right, that'll do. It's a wrap.